Welcome to the Love is the Cure Foundation podcast. I'm Alfonso Vega.
And I'm Lyndell Vega.
Our goal at the Love is the Cure Foundation podcast is to have conversations that are valuable to families as they go through their own pediatric cancer journey. Our aim is to offer families an understanding of what their journey may entail when their child is diagnosed with cancer. On today's episode, we are speaking with Doug Richardson. Doug is a nurse on the neuroscience Neuro-Oncology floor at Boston Children's Hospital. Since our time at Children's, Doug is now a nurse practitioner. Congratulations are in order, of
Yay.
course. We are speaking with Doug today to get a better understanding of the nurse's role with the daily medical lives of a cancer patient. We feel it is really important for parents to understand some of the things that they may encounter as they go inpatient on a neuro-oncology floor. Inigo had a great relationship with Doug. Doug was one of only 2 male nurses on the floor at the time. It seemed like Inigo appreciated that, and Doug and Innie became buddies. Lindy and I care about Doug a lot as well. Beyond all the fond memories that we have with Inigo and Doug, Doug was also present at some breakthroughs for Inigo and at some very difficult moments for Lindy and I. Doug was Inigo's nurse the day that we built a RC crawler course out of Inigo's hospital bed, and for the first time, since Inigo's diagnosis, he was able to drive his RC cars. Doug was also the charge nurse on the night where we all ended up having a meeting at 2 o'clock in the morning about whether any further interventions for Inigo would go forward. He was there with us as we made the decision that no more decisions needed to be made. He was Inigo's buddy to the very end, and we are expressly thankful of how smoothly he became part of how we worked in our hospital space. He saw how we communicated, he saw how we worked with each other, and he took part in Inigo's journey in the same way. And that's the intro. Welcome to the Love is the Cure Foundation podcast. Thanks for coming, Doug.
Thank you guys for having me, and thanks for that great introduction.
Thank you so much for being here today. So we just want to hear it from you now, Doug. So tell us a little bit about yourself and what you do.
Yeah, so like you said, I'm a nurse on the inpatient neuroscience unit at Boston Children's Hospital. Similarly to probably, I think, Carly, who's been on the podcast before, kind of explained, we have neuro-oncology patients, neurosurgery patients, neurology patients, epilepsy patients, and all other patients that come to Children's as well. So we're a very specialized unit, but we also have a very broad scope in neuroscience as well. I've been a nurse for over 6 years now on the unit. That's all I've done in nursing, so it's kind of all I know at this point. And in addition to being kind of that bedside nurse, kind of, as you talked about, I've transitioned into being one of the charge nurses on the unit, where you can kind of see things from a different perspective and kind of work with the hospital as a whole more than just the patients as a whole. So yeah, it's been a good time on the unit. Challenging times, inspirational times, and a lot of bonds made over the years.
Thank you. So Doug, as we begin this episode, we think about our families who are just arriving there on your unit and some of the emotions involved. Some of the biggest ones that we remember feeling is, the anxiousness of the unknown, fear. So can you describe some strategies or techniques that you use to help pediatric patients and their families who are feeling anxious to adjust to the neuro-oncology floor? And then how do you tailor your approach to meet those needs of both the child and their family?
Yeah, so I guess that's a great place to start. Kind of thinking about this, I'll go back to kind of my nursing interviews that I went through, like applying for jobs. I think one of the best ways that I personally help is kind of trying to read the room. There's some rooms where like the kid is in control and the parents respond to the kid. There's other rooms where the kid or patient responds to the parents more so. So one of the first things I try to do is try to figure that out. And there's some rooms you walk into and the kid's not going to respond to you well unless you gain that trust of the parents. And there's other rooms where you need to gain the trust of the kid first for the parents to finally connect to you. So I think that's kind of the first thing I try to gauge as a nurse, is how can I let this family feel more comfortable with me? How can I let this patient feel more comfortable with me? And once I kind of establish that, kind of go into the next steps of just providing resources to the patients and the families, like simple resources as like, hey, there's a garden on the 11th floor. If you need a break, it's a great place to go. Or the kitchen's right across the hall. If there's not coffee there, let us know. We can make you coffee. It's kind of the more simple things, the basic needs for the patients and families. Provides like some security and normalcy to that first initial process. And then from there, other people on the podcast have kind of talked about it too. You have to figure out to the families what their strengths are, what their weaknesses are, and like and help them establish what kind of role they want to take in the care of their patient, what they want to know, what they don't want to know right away. I think is very important.
How do you gauge that, Doug? How do you gauge, like you're saying, there's a lot of information flying at us as parents when your child is diagnosed. And I think in very many ways for myself, I felt a desire to try to figure out what it is that I was worried about Inigo needing to know. How do you guys gauge that when speaking to the parents? I know that you're saying that you kind of feel that, right? As you walk into the room, you kind of start to understand, is this a child-driven room? Is this a parent-driven room? But then the medical conversations start to happen and the medical teams get there. Is there something that you do previous to bringing information to parents, like out in rounds, that you discuss? Do you discuss it in rounds like, hey, this is what I have observed works well in this room? Or is that not something that you guys discuss?
No, that's definitely something we discuss. I think, especially in those first couple of days, everyone's trying, of you guys being on the unit, everyone's kind of trying to figure that out. Sometimes the nurse practitioner might have visited you guys in the ICU prior to coming up to the floor. Sometimes your primary oncologist may have gone down and talked to the family before. Or maybe kind of one nurse has spent a little more time with you than the other. I think in rounds, we definitely, whether it's the nurse practitioner, the attending physician that's on, we kind of bring that in saying like, hey, this family seems like they're still in a grieving process. Let's not throw a lot of information at them today. Like, let's kind of focus. Sometimes we keep things more step by step. Or I could be as a nurse like, hey, I walked in at 8 a.m. and the parents had a notebook full of notes already and questions and stuff. Like, I think we should put aside some time to kind of talk that out. Whether sometimes it doesn't happen first thing in the morning with rounds. Sometimes it's great. Keep writing down your questions. We're going to circle back this afternoon and kind of talk through them. But it's definitely a conversation we have a lot during rounds and continue to have like kind of daily throughout the stay as parents either progress through their grieving process of the diagnosis or their eagerness to learn or different things like that. And I think having been a nurse for 6 years, some of it comes, it's a lot of intuition, but on where the parents are at and different things. But some of the big tellers are sometimes the parents are still sleeping at 8 a.m. and kind of behind a curtain. Other times the parents are like the first person to say hi to the nurse when they walk into a room, and different little telling things like that kind of help us know where families are at and where patients are at.
Because I'm not a nurse like both of you guys are, I love hearing what goes on behind the scenes. And I do really appreciate the the work that is unspoken that you guys do. I think so many times we talk about nurses and it's a medical process, a medical checklist that has to happen that you guys go through. But I love hearing the assessment side, and because that's also something that you guys are trained in. But I just love that hearing the assessment side of trying to understand where a family's at, where the kids are at, where the parents are at, and then you fulfilling the role that you need to within that space. I think that's super important.
Yeah. It was a delicate balance, wasn't it, to kind of try to assess where our family's at. And as you're saying, each family is at, each one has a different family dynamic. And it is important to consider these things, whether it's outright, depending on the family and the patient, whether they're ready for that, up front, or if they just need a little time. We really did appreciate how you catered to us.
Well, in very many ways, Doug, do you see your role as a nurse as the communication liaison because you're with the patient most often?
Yeah, I would say so. I think of us kind of as like you could say communication liaison, a facilitator, different things like that. Because we do have the tasks and things we need to do throughout the day, and some days that's all we can do, to be honest. But
Yeah.
there's the other days where we have the time in between that where we really are communicating, like, what does the patient need today? What do the parents need today? And how can we go about that? And I think as nurses, as we get more experience, we know our limitations as well. So some people, like a nurse like Carly, might be like, oh, this patient really wants to do this activity today, and I'm going to carve out time to do that. Someone like me who can't sing, color, draw, I don't have a creative side to me really. That's when I go like, hey, where's my resources on the unit today? And like, how can I pick someone out that can help facilitate what this patient needs? And maybe I can focus on helping the parents learn something new today or build their confidence or different things like that.
Yeah. And then maybe you can't sing, Doug, but your skills are in other places. That's okay.
We all have our talents, Doug. I never minimize what you could do. So.
Yeah. Yeah. I do appreciate when I say communication liaison, I know that in very many ways, you for us were the go-between when you needed to let the MPs on the floor or somebody. Very many times you could make the decisions that were needed when we were asking questions or needed help with something. But you also were the communicator between the next level, the next escalation that needed to happen. And I think that's very skillful how nurses do that and understand their communication prowess. And that's got to be difficult. That's got to be difficult for people that maybe don't know who to trust when your child is first diagnosed with cancer. And I think that's one of the most difficult things for us when we, as parents, when you walk onto the floor, is you're trying to figure out who's on your team. And I don't mean like medical team or this and that, the other, but you're trying to figure out who is going to work with you best. Just like you're saying that you try to figure out where the child's at, where the parent's at, so that you can communicate with us. We, in very many ways, do the same thing to try to understand, because there are some nurses we get along better with. There are some MPs that we get along better with. And I just mean that on a human behavioral standpoint. Very many times we are looking for who is going to jive best with our son, with Inigo, because that meant a lot to us. So I think it's really great. Beyond the checklist, I think it's great the communication skills that you guys have to facilitate our needs as parents.
Yeah. So Doug, moving forward here, still on the topic of like parents' anxieties, patients' anxieties, one of the things that parents think about in particular is, medical interventions. The topic can be challenging because a brain tumor diagnosis often comes as a complete shock. And then all the subsequent medical interventions are things that no parent ever expects their child to have to go through. If you could you talk a little bit about some of the common ones that, parents and patients might see early on with this type of diagnosis?
Yeah, so I think it is very important to talk about that stuff in the beginning, especially with brain tumors specifically. In terms of oncology, brain tumors tend to look, feel, and act a lot differently than kind of the other day-to-day kind of what people think about when they think about cancer. Since the tumor is in the brain, it has a lot different effects on how the patients function and different processes in the background going on. So the things that we always talk about kind of are central lines, whether it's a port, a PIC line, or an implanted central line. That's kind of an inevitable for all of our oncology patients for the most part. So we often talk about that being an intervention is probably one of the first steps, either if it happens during their first tumor resection or surgery or in the weeks after, as kind of something that's needed or required to go through with management. Some of the other things that we start teaching about early on when chemo is initiated is kind of basic blood count information. So for our neuro-oncology patients, typically our chemotherapy and some of our more, I'll say, standard regimens last like 3 to 4 days of inpatient chemo. And then there's a period of 3 or 4 more days, if not a little bit longer, where the patient might still feel kind of well. And then at that 10 to 14 day mark, their blood counts will drop, being their white blood cells, their red blood cells, their platelets. And that's kind of when the patient will feel the worst. They most likely will end up needing blood products. They'll need to kind of stay away from friends or family outside of the immediate care team to kind of prevent from infections and things like that. And that period can last days, it can last a week or so. So there's some of those things are the expectations we kind of talk about. And during that low period of blood counts and things like that, the patients often come back into the hospital to help with management of that. In those scenarios as well, we talk about kind of skin integrity and keeping their skin maintained, because all their mucous membranes are breaking down and their wound healing is a lot harder to keep up with and control. And that often comes with pain as well. So we talk about kind of pain management and expectations that chemotherapy at some points is going to be very uncomfortable. It may be painful. So those are kind of, in general, the basics of just chemotherapy and oncology in that sense. Often for our neuro-oncology patients, external ventricular drains are something that come up, as well as VP shunts. So many of our patients, they have developed a condition or already have developed a condition of hydrocephalus, where there's the pressure inside the brain is too much for their brain and body to handle. So they need a second drain or shunt to help get rid of some of that fluid and decrease that pressure. Often that is brought up sometimes before the first surgery with the neurosurgeons, because it is somewhat of a realistic complication of the first surgery of a tumor resection. So that's often brought up then. And then sometimes it's brought up later down the road, because it can occur in the weeks or months following the initial surgery as well. And I would say if the EVD is not brought up or a shunt is not brought up during that first surgery, it's often mentioned early on, but we don't go into much detail about it, because it is it's very foreign to someone who's not in the medical field. And it's foreign to many people that are in the medical field still. And it can be kind of a scary thing to think about.
Yeah.
And then also, if that does end up coming up, it can be a scary thing to see, is having your son, daughter, child come out of a OR with a drain coming out of their head. So I think some of those things we approach more so as they come up rather than kind of laying it out there in the beginning.
Gotta keep things medically relevant. We understand that because you don't want to scare anybody. But these are some of the common things that you might encounter.
And I think that's important for parents to understand too, is that early on in your child's diagnosis as a parent, I think you're going to be spooked easily. There's a lot of things that
just comes with the territory.
That from one day to the next. And I can speak to our situation specifically. When we came upstairs from the ICU, that was about 3.5-4 weeks after Inigo's tumor resection. And it was only after we were up on the floor that there needed to be, I don't know if it would have been considered an emergency intervention, but it was decided only after we had come up to the floor a month later that Inigo did need a shunt placed. And I think that was probably the first time that I did not deal well under pressure with this. I think I had done okay for the first month, but that just felt like, here he was finally starting to heal from the incision, from the tumor resection and all that sort of stuff. And then now he needs a shunt.
Yeah.
And I was so, I think we both were so in love with Inigo's hair. And so,
and he was in love with
his hair too. And, obviously you're aware that your child has cancer through the treatments. They're going to lose their hair. But I think it hit me differently. I don't know, to realize that we were going to be placing a shunt on his skull, in his hairline, in a place that I was more stressed about how he was going to feel with the visual change of something like that. And so, I appreciate that you said that, Doug, that it's important to give information when it's necessary.
Yeah.
And I would say it's important for us as parents to understand we're going to spook easily, especially with these earlier months where it's still very raw to us. And the shunt placement for me was one of those moments because I cared about how Inigo was going to feel when he saw that, and how that was going to change his visual appearance in a different way.
So, Doug, were there any others of importance you think that are, generally common for patients like this that maybe parents and patients should be aware of?
Yeah, so I just want to comment on one thing about kind of the shunt and the EVD thing as well. Just thinking about things, how you were saying you seemed like you felt like you were responding kind of well to how things were going, and like the initial brain tumor and surgery, you kind of felt like you were in control of your emotions and like how you were acting to some extent. And then the shunt came along and you were like, what now? Like, how do I respond to this? And that's often something that we see a lot with families is like everyone unfortunately knows someone affected by cancer and they've heard the word cancer many times, but things like shunts and EVDs are very foreign. So you get through that first part, and then all of a sudden you have this new thing that you have no idea about. It's foreign to you. It changes something about your child that you didn't expect. So it starts like a whole new grieving process for families almost. It's like, now I lost this. Like, I knew my child had cancer, but now they have cancer and now they have this as well. And it changes the way parents think about things a little bit. I think as nurses, we see that. And sometimes as nurses, we can almost, in some ways, diminish that because we're so used to it on our floor. I would say like 50% of our patients probably, or less than that, but a large portion of our patients have shunts and EVDs and things like that. And it's one of the more basic and common things we see, but it's completely foreign to families like you guys.
It is interesting because now I realize that a shunt is completely common to a child that has brain cancer. But I guess at the time, once again, I will continue to reiterate, I don't have any sort of medical background. During the early stages when Inigo has his tumor resection and they're talking about opening up another ventricle and they're creating space for draining, as a parent, you go, oh, awesome. Like, we won't need anything external to take care of the hydrocephalus. And you're just, because you have no idea, you're just thinking like, okay, like this is good. And Doug, I think something that you said there is super, super important. A lot of this, a lot of my issue with the shunt might have nothing to do with the shunt. It's just simply another grieving marker where it was something else that came up that psychologically within me, it was a moment where I could feel aggrieved by something else that was happening to Inigo. And so it might have simply been, not anything to do with the shunt, but simply like, what else is this poor kid going to go through, And I think you're right. Like, shunts are super common. Probably all of your kids have shunts. That's a normal process when it comes to brain tumors. But for me, it wasn't. But maybe it simply had to do with another point where I could allow myself to grieve, because I know for that first month, and I had prayed about this too, I wanted to be very mentally stable for Inigo. I wanted to be very mentally stable for Lindy, because I wanted to be a good and efficient team. I wanted to be able to help Lindy with what she needed. I wanted to be able to help Inigo with what he needed. And I think for parents listening, I think for you, you're going to have the same feelings of wanting to be an efficient team member. I think it's important for us to understand, just as we were talking to you, Doug, and you have specific roles that you're trying to fulfill. As parents, you'll start to figure out that same thing, that there are specific roles that we want to fill in our own space to make our space more efficient. And sometimes these medical situations pop up that are just, it's okay to not feel in control, and it's okay to grieve through those things. And the shunt very much was my moment of realizing that I didn't have to be strong. For Inigo and Lindy, I didn't need to, I could be upset about this. And even though I did it personally and I didn't do it out in the open, well, that's not true. I think Allie was our nurse and she saw me cry that day or something. But seeing me be emotional wouldn't be anything of a surprise to you, Doug, would it? But the shunt was definitely, I can look back at that moment in particular and say that it's a normal medical process that will happen to children with brain tumors, but it was definitely a marker for me that was difficult for me to deal with at that particular time. One of the things that is most, I think, it was heavy for me as a parent. So beyond the shunt was a chest port, and the realization now that the chest port is really like one of your main interventions throughout your entire process as a cancer patient, brain tumor or otherwise. So can you speak to us a little bit about the mechanisms of the chest port? What exactly are its,
why is it needed as opposed to an IV line?
Yeah, so the chest port, it provides us constant access to administer drugs, specifically chemotherapy, hydration, as well as draw blood work very easily. It's supposed to be very easy. So the chest port, it sits in the chest underneath the skin. If you touch it, it feels almost like a rubbery kind of material, and we use a needle to access it. And then it also provides, we are able to access it with the needle, and then we are able to de-access it, so that it just sits under the skin and patients can kind of go about things on a day basis without a tube coming out of them. So alternatives to that, some patients will have a PICC line, which is a central line that sits in the arm, that also allows us to give medications and draw blood work. But those, since they're constantly in your arm and they're exposed constantly, they're at higher risks of infection, and they're harder to deal with for families at home. So yeah, ports are the most common thing seen in our, especially our patients kind of around Inigo's age. And they can be very stressful for families. They can be very stressful for patients. We are using a needle to access them. So some patients, this is a huge stress for them. They're scared of it. It hurts. It's uncomfortable. They're afraid of needles. So often we put cream on, an emla cream to help numb the site before we place the needle. And then sometimes patients have ports that are hard to access as well. So sometimes they need multiple attempts at accessing, which can be stressful for the patient. They're just sitting there waiting for a nurse to come in and do this, and then they attempt it, and it, for some reason, doesn't have blood return, or it works for a second, and then it seems like it's not in the right place, and then they have to wait again another 20 minutes to put lidocaine on again, and then reattempt. But it is something that the patient has while they're in the hospital. They go home with it. It's accessed at Jimmy Fund appointments. It's accessed when they come into the hospital. So it's almost their lifeline, but it's also in some sense, because we can have constant access to give them medications, blood products, and draw labs. But it's also a huge stressor for patients and families to kind of manage.
Chest ports. It's a whole nother thing.
Yeah.
Yeah. I wanted you to specifically talk about that because it is it's the main tool throughout this entire journey. As you're saying, like the access of it. Yeah, at Jimmy Fund, it's like a factory. Like they can throw a dart and get that thing right in the port. It's amazing. And shout out to the Jimmy Fund that's today going on. So that's awesome. Those guys really do a lot to raise awareness and to raise funds for cancer treatment for kids. That's really awesome. But yeah, chest ports, I specifically wanted you to talk about that because everything that we did through that entire journey, whether it was Inigo getting blood because his numbers were low, whether he was getting platelets, whether he was just chemo treatments go through that.
Other medications. Yeah. It was pivotal.
And Doug, chest ports, for people to understand, that's not just going under the skin like your arm would be. That's going directly into the heart. Is that correct?
Correct, yes.
Yeah.
Yeah. So it also gives us assurance as a nurse and the medical team and the family that this medication is going into the bloodstream where it needs to go. If you're using IVs or something like that as well, they have a high risk of infiltrating, which essentially means the medication is not going into the blood vessel, it's going into the surrounding tissues. And in high-risk medications like chemotherapy, that can be very, very serious and scary situation. So another reason why the port is extremely, extremely important to have, because it gives us that assured location and method of giving medication in these blood products.
There are a couple other things. So the chest port was also important for feeding Inigo when he needed TPN. When he was getting fed through a normal tube, or I wouldn't say normal tube, but just a tube that goes into NJ tube. Or, those go more into your, I should let you say what it does, Doug. So if a child is not getting fed TPN, which means they're getting fed molecularly through their chest port. What are the other ways that you can feed kids?
Yeah.
Which is probably a more normal process on the floor, I would guess.
Yeah. So, kind of as we're alluding to here, a lot of the patients, when their counts are down and they're not feeling well, their gut's not working great. So it's hard for them to absorb nutrients. It's hard for them to keep down food. So often they will get what we call TPN or PMN lipids through a central line like a port to give them nutrition. More commonly seen is an NG tube, which will go through their nose and down into their stomach. That's probably the most common thing we see on our floor. Other things along those lines would be an NJ tube, which is slightly lower down, which provides some patients with a little bit more rest to their actual stomach, and provides the nutrients lower down the GI tract, so they're not as nauseous and having as many feeding issues. And then the next step after that, we can tell that this patient has more chronic feeding issues and feeding needs. They may end up with a G tube, which is a tube that will be in their stomach, and will be kind of permanently, even though it is reversible, but more permanently surgically placed into their stomach to provide nutrition. And we often rely on those methods to provide our patients with nutrition. If you talk to a nutritionist, they would talk a lot more about the protein needs and fluid goals and different macronutrients that the patients need during their treatment. But on a more basic level, we want our patients to have the proper nutrients throughout their treatment, so that they can feel well, they can do things when they're feeling well, that we can promote wound healing, and just let their body function as best as it can in this state of while they're getting chemotherapy. The NG tubes specifically, they're great because they're somewhat easy for us to place. They give us a route directly to the stomach. We can give meds to patients when they're not feeling well or they're having trouble eating or swallowing. At the same time, they come out often. Patients can simply get their finger caught in them when they're moving or turning. While we're changing a patient or something, they can just come out, or if they're at home doing things, and then they have to be replaced frequently as well. So that can be very frustrating. And like I said, for us, it's fairly easy to place them. For patients, it's super uncomfortable. Someone's forcefully putting a tube down your nose, down your throat, and into your stomach. And if anyone has ever had that done to them before, it is very uncomfortable. You want to resist the whole time. It makes you want to throw up and gag. And the more the patient is upset, the harder it is for us. And then they meet resistance and becomes more uncomfortable. So it's kind of similar to the port. It's great for us. The patients hate them. But when they do work well and we can provide adequate nutrients to the patients without having to worry about harping on them like, you need to eat more of this, you need to eat more of that, kind of provides one less thing for the patient to worry about while they're not feeling great.
Feeding tubes.
Yeah.
Yeah.
Inigo did have to have that early on. I think after maybe his second or third round of chemo, he was to the point where he was able to swallow again, and
once he could speak again and eat again.
Safely. Yeah, swallow safely.
Yeah, I don't know. He refused to not eat. He loved to eat. Yeah. And so he decided that he was not going to have tubes placed anymore to feed him. So, but that's not to say, I think it's important for parents to understand what we're saying here too, is that these are important interventions that are really, really helpful to your child. And a lot of times, I think just like the shunts, I think feeding tubes are probably very, very common. Is that right, Doug?
Yeah, they are very, very common. And kind of something to add on to it as well. Indigo came in with a love for food, and he enjoyed a lot of different varieties of food. And not all of our patients have that. There's some patients that their diet is Wednesday pizzas, Thursday hot dogs, and different things like that. And while it's fine to maintain at a baseline for some kids, while you're going through chemotherapy, you need the full range of nutrition. And often pizza twice a day or a hot dog every now and then, or half a water bottle a day does not kind of cut it for the needs that you have as a patient when you're going through chemotherapy. So in some of those kids, it's much more needed. And then in the younger kids as well. Most young kids, when they don't feel well, the first thing to go is their stomach. They don't want to eat. They don't want to drink. If you think about like if you had a child that like had strep throat, they're nauseous. They're not going to eat anything. They feel terrible. But if your kid is 12 and they have strep throat, they're probably still going to eat some of the foods they want, and so be able to drink fluid and things like that. So some of the younger kids need those interventions a little bit earlier.
Yeah, I think another thing you mentioned that's important for parents to understand is that, things like feeding tubes, you had mentioned, can be temporary. They're not something that's in all the time. Like the child's needs can change. And when they're feeling a little better, maybe they don't need the NG tube, or they're able to fully recover, and the gastric tube can be reversed. It can, have surgery to remove that. So I think that's important for parents to know too, is that these things with feeding, they can change all the time. They're not necessarily a permanent fixture for your child in all cases.
Yeah, and it's not to scare anybody. Yeah. It's just, I think it's really good to understand, and maybe it was good for me to understand, because you were aware of some of the things that could happen and that could be helpful to the teams. I wasn't aware, and so I think it's really good to help parents understand, like shunts, ports, chest ports, and feeding tubes. Doug, would you say that those are the most common interventions that would happen for a brain tumor patient?
Yeah, as in terms of kind of devices or things being placed in a patient or used to kind of help them through treatment. Unfortunately, some of the common things that we see associated with our brain tumor patients as well is our patients end up with seizures, which is, it's not a medical intervention necessarily, or it's not at all, but it takes intervention, and sometimes that can be again a kind of this big turning point in how parents think about their child as well, and think about what's going on, because it's often very unexpected when it happens the first time, and it can present as the seizures can present as like a generalized tonic-clonic seizure, which is full body shaking, kind of what, if you've ever thought of a seizure, is what kind of your lay person might think about, is the person kind of convulsing on the ground, drooling, foaming. That can be kind of an initial presentation, which is extremely traumatic it's traumatic for nurses to see, it's traumatic for parents to see, it's traumatic for patients to go through on small and big levels. So that is something that it's normally when they occur in our patient population of neuro-oncology, it's something that we kind of plan for and predict may happen, but it's always comes on unexpectedly. It's not like we're like, oh, this patient looks like they're probably going to seize in the next week. It's kind of like, in terms of hydrocephalus, we can do MRIs and imaging to kind of track this. There's no way to really track your seizure potential. We don't prematurely track that. Our patients are often put on general medication for epilepsy or seizures, or Keppra or levetiracetam. I don't want to pronounce it correctly, but levetiracetam, when they go into surgery and for a short period after surgery. But that medication sometimes comes off. So it's something, again, that's talked about, but we're not like, hey, Jimmy's mom and dad, please look out for your son or daughter having a big seizure. Um, so it's one of those things we kind of address as it comes, and that can be another big turning point for families kind of in their grieving process or how they deal with things. Can be very shocking and scary.
Yeah, I can only imagine. We did not have that situation with Inigo, but we were, it was communicated to us, and so it's something that we were aware.
Yeah, it was always a precaution.
So brain tumor resection, we talk about EVDs or shunts being put in. We talk about a central line put in. We talk about feeding tubes and the necessity for something like that. The possibilities of seizures. And we talk about specifically with the chest ports, blood products, chemotherapy medications, and all medications go through that. One integral part to most kids that have to go through treatment for a brain tumor is radiation. Can you tell us a little bit about radiation? Because, well, I want to just leave it to you, but I do want to say it is the one thing that is not done on the floor. All those other things can be done on the floor or in the specific facility, but radiation is a bit different. Can you talk a little bit about that, Doug?
Yeah. So I would say a lot of our neuro-oncology patients do end up going through radiation. Typically, I'm sure if you ask Kate, she would have a little more, but we kind of, under a certain age, we won't do radiation. And over a certain age, we will do radiation. And again, it depends on the tumor and different kind of features in that sense. But at Boston Children's, we don't have targeted radiation therapy for cancers. So we will go over to the Brigham, which is attached to our hospital, for the radiation therapy. And how that process normally looks for our patients is we do kind of, there's a mapping session, there's a trial session, which will bring the patient over. It's a fairly long walk. It probably takes like 10 minutes. I'm sure you guys know the time better than I do, because we made the trips many times. But we kind of take this lonely walk through hallways where you don't see a lot of people, up a ramp, over a bridge, into a building with all adults that aren't as friendly as people at Children's, just because of the makeup of the hospital. Not saying they're not good people, but at Children's, people are more welcoming and kind of have a lighter, I would say, a lighter outlook on things. We squeeze into a tiny elevator, and then go down to the radiation suites. The radiation team down there, they have child life specialists just like we do at Children's. They have their own nursing team and physicians there as well. So separate from your inpatient team, you have another kind of radiation team. They work closely together, but they are two identities, I guess, as part of your team. And then from there, the mapping process typically happens. And the patient is put into kind of on a hard bed, we'll say, and into a machine where kind of images are taken, and they're fit with a mask to help keep their face completely still, and it has to be form fitted to their face because we're emitting high radiation beams at a very, very specific location. And we don't want to affect other areas if we can, that aren't affected by the tumor, if we can help it. So it needs to be patient needs to be very, very still and have a very specific point of receiving the radiation. And that can be a very traumatizing thing for patients. Many of our patients need sedation for it, which I guess is another intervention that happens pretty often for our oncology patients, is sedation, whether it's sedation for MRI, sedation for getting radiation. which in itself has its own risks and benefits as well. And the radiation can go, there's different durations of radiation that patients will go through, and intensities as well.
Doug, you got tasked with a drier, more difficult podcast episode. And
it's a lot of information, but we appreciate it.
Yeah, a lot of information, but that we feel is important for people to understand that, where you're going to deal with a tumor resection primarily. And then from there, it's going to span out in a bunch of different directions, depending on what your child needs. This is obviously a very niche podcast where we try to offer insights into what your journey may look like as a parent with a child with cancer. And so it's important for us to highlight some of these medical connections that you're going to end up doing. The reason why we wanted Doug to do it in particular is we wanted to understand it from a nurse's perspective, because it is the nurse that is usually going to be facilitating all of these things through the orders of your child's care. And so when your child has a tumor resection, they come back to the room, and it's the nurse that's taking care of them and communicating the situation to the parents. And that happens with all of these things. So whether it's the chest port, or whether it's radiation, or any of these things, you come back to a room, your hospital room, and it's your nurse that is facilitating your questions, your recovery,
and teaching
you
about all of these things,
teaching you about wound care, teaching you about the food, the formula that's going into the pump that's feeding your child. It's in your hands. And Doug, I understand that. Congratulations, you're MP now, and so your role obviously changes. But I think it's important for parents to understand, as we've talked about before, that your nurse becomes your first line of defense, or your first source of information, your first source of facilitating, trying to get comfortable in a space that you're not comfortable with.
Yeah, so in closing, Doug, is there anything or any important points or tips that you would give to parents of a newly diagnosed child?
Yeah, I think kind of some of the points that you guys touched on is identify your care team within your care team. Kind of like there's going to be those people that like your personalities match up with great, that you feel like understand you or understand your child more, and use them as much as you can. Because when these things come up, often as a nurse, we get asked, what do you think about this NG2? What do you think about this? Do you think we should try it without this MRI without sedation today? Do you think this? Like, how long is things going to be? Ask your nurse is your safe person. They're not like going back to someone else and being like, why the heck did this parent ask me that? Like, these are things we expect parents to ask us. And we can give people, I would say, pretty reasonable and accurate information in terms of different things, like because all these interventions, they have pros and cons to them. So we can give you that information and like give you our opinion and help you kind of through those things. So identify those people, identify questions you have, and go to those people with those questions. I think it's super important.
Yeah. We did that a lot to you, Doug, where we would say, rounds would finish and we'd say, or I would say to you, because Lindy she knew everything, but hey, Doug, I would say, what do you think about, A, B, C, and D? And your communication is always great, like filling us in. But exactly what you're saying is just this, you do build relationships with your caregivers. And I think it's really, really important to identify who they are. Doug, we appreciate you so much. Indigo appreciated you so much. As you know, you facilitated some really fun moments with Indigo, with playing water gun wars in the room and stuff. And it was just great. It was great. The relationship that we formed with you allowed us to feel safe in that space when you were with us. And, you know, there was always a smile on Inigo's face. He loved all of you. But, you know, there's Doug's name written up on the board, and Inigo gets Doug for the day, and there was always a smile on his face.
Yep.
And so that was appreciated. Just a good, kind-hearted person that you are. Nurses need to be that, and you are definitely that. And we just appreciate it so much. And then we do reach a point where our relationship with you is such that at the very end, you're a charge nurse, and we're having a meeting at 2 a.m. And the conversation with you and with our nurse for the night, Jacqueline, and the surgical teams that were there to discuss certain things with us. And as parents, you will reach a point where you need to make a decision for your child that goes against every grain in your body. But it was the right thing to do for our son, to decide that there were no more decisions to be made. And you were right there with us, Doug. You saw us through that. You allowed us to feel safe in making that decision. And I think we even discussed it with you afterwards about what you thought, and your kind-hearted acceptance of our decision meant a lot too. And I think we cannot reiterate to people how important it is to build relationships with your nurses for your child's sake and for your sake, your mental health, as you go through this process with your child. So, Doug, you got tasked with a very dry episode of very structural things that are important, we feel, for parents to understand you're going to go through. But in closing, I just want to make sure that we reiterated that beyond the structural medical things that are going to happen to your child is also a person with a heart that is facilitating these things for you and your family. That's and right. So, Doug, we appreciate you. Thank you.
Yeah, thanks, Doug.
Thank you both. I appreciate you guys very much as well. You guys mean a lot to me as a person. You guys were great. I was excited, the same as you were, when my name was on that board that day. And I enjoyed getting to know you guys and throughout the whole process. And something that I always remember, it's something that I said to Indigo, but I remember in the last couple of weeks, while you guys were at Children's, I went in one day and I was just like, it just came out. I was like, I want to be like you when I grow up, Indigo. He was just such a special person. He was so curious, caring, happy. And that's something that I think was just born into him, and something that you guys put onto him as well. And it was just amazing to kind of see that throughout the whole process. No matter if it was Indigo's best day or his worst day, I think as nursing, which was nice, we always knew that you guys were going to be the same people you always were, and Indigo was going to be Indigo. So it was awesome for us as nurses to take care of you guys. And not all families can go through that same process and have that same thing, but I think as parents, you guys did great jobs of leaning into your strengths and then reaching out to others for help in the areas where you it wasn't necessarily your strong point. So I think that's something for parents to take home with. You don't need to change when your child is going through this. Lean into what you have as strengths, whether that's you're a millionaire, you can purchase people to help you with things, or whether it's you're very caring and thoughtful and you can be by your child's side the whole time, or whether that's you have medical experience and you can kind of navigate those things, or you have a huge family and they can help support you every single day or be there with you. Figure out what your strengths are and kind of lean into them. And then those areas that aren't your strengths, look for help, because your nurses are there to help you and your medical team is there to help you.